Hey guys, in this video I have included the mustknow and the frequently tested points from breast carcinoma, and the important points and the scorings are also made easy. The TM staging and Van Nuys staging made easier. So let us start with the carcinomas itself first, and then later I'll explain the anatomy wherever and whenever required. So let us start with ductal carcinoma in situ now. So ductal carcinoma in situ is of 4 types: papillary, cribriform, solid, and comedo. Comedo has necrosis, so it is having bad prognosis. And ER-PR, that is estrogen receptor and progesterone receptor status, is also negative in comedo necrosis, and further telling us that it is having a bad prognosis. Whereas papillary is the most common one. Cribriform, solid, all these 3 together have ER and PR positive, so they have good prognosis. When we talk about the most common malignancy in the screening mammography, whenever a patient or whenever a female comes for screening, the most common malignancy detected here is Dcis. So the important points regarding Dcis are: the surgery we do is breast conservative surgery plus radiotherapy. Chemotherapy has no role in Dcis. This is an important point. When ER-PR status is positive, you give hormonal therapy like tamoxifen. And the important point from pathology here is that there is a marker called as P63 marker. That marker is for myoepithelial layer. Okay, so when the cancer is in situ, when this layer is not breached, this comes positive. When the cancer is invasive, when the layer is breached, this marker becomes negative. So this is an immunohistochemistry marker. It comes negative when the invasive cancer is there. It is positive in situ. So that is what I have concised here. When P63 we talk about carcinoma in situ, it is positive. Invasive cancer, it is negative. Coming to PAS, that is which gives pink color, right? PAS gives pink color to the basement membrane. When the basement membrane is intact, we can conclude that it is carcinoma in situ. When the basement membrane is invaded, then we can say that it is invasive cancer. So this is regarding the DCIS. In the DCIS, when we talk about the management, we have something called as Van Nuys grading. So Van Nuys grading is used for DCIS. Based on the score of Van Nuys grading, the management depends. So higher is the score, bad is the prognosis, and larger will be the surgery. That means the bigger is the surgery. Okay. In Van Nuys scoring, at the outset itself, remember that ER and PR status is not involved in Van Nuys grading. What are involved are scam is involved. Okay. So size, C for class or grade, A for age, and M for margin. Margin is measured in both M's, millimeters. So remember this point. In TNM staging, it is about centimeters, but here it is millimeters. In margin status, M and M, it is millimeters. So size, class or grade, age, and millimeters. As the size increases, the prognosis is towards bad side. As the class increases also, it is towards the bad end. And age and margin decreases, it is towards the bad end. Remember like that, first 2 increases and next 2 decreases in this grading. That is scam. Now let us discuss about the Van Nuys grading in detail. So remember the number 2, score 2 first. So in size, S for size, right? And C for class, A for age, and M for margin. Repeat it with me so that you will remember for longer time. So when we consider about size, we take it as 16 to 40 mm. So everything is mm in here. Margin is also mm and size is also mm, millimeters. And when we talk about the class 1 or grade 1 or 2 with necrosis. And the age is 40 to 60. So remember it as 16 to 40, and here is 40 to 60. This is in years. Coming to margin, it is 1 to 9 mm. So as already discussed, size and class. Firstly, size should be increased, right? When the score is higher is the score, bad is the prognosis, and higher is the size, bad is the prognosis. So we should increase the size, right? So here it becomes greater than 40 mm, and here it is less than 16 mm. When we talk about necrosis, 1 or 2 with necrosis, here it is 1 or 2 without necrosis. Here it is grade 3 with or without necrosis. Okay. Coming to the age should decrease, right, as we go towards the higher end. So here take it as 40 to 60 is taken in middle. So here it will be greater than 60 years, and here it will be less than 40 years. When we talk about margin also decreases, right, 1 to 9 mm. So here it will be greater than 9 mm, and here it will be less than 1 mm. So if you remember like this, it will be easy. In the books it is given like less than or equal to greater than or equal to 15 or less than or equal to 41, something like that. So just remember this score so that it will be helpful for you. And when you match and see, it is almost, it is like exactly same only. Remember, like 16 to 40, less than 60, greater than 40, 16 to 40 and increase it to 40 to 60. So you'll get the score. When we talk about the total score, it is like 4 to 6, 7 to 9 and 10 to 12. The highest you can get is 12, right? Because there are 3 scores and 4 columns. So 4, 3 is 12. So higher is 12. When the score is 4 to 6, the treatment that you do is wide local excision. When it is 7 to 9, you do wide local excision plus radiotherapy, because the size is increasing, right? And I mean, everything is going towards the bad side. So you need to do something higher, surgery or something. So you add radiotherapy to the surgery that you did. That is the excision that you did. When we talk about 10 to 12 scoring, we do mastectomy. So this is about DCIS, value scoring. Scam. Now let us talk about LCIS. Since we talked about DCIS, let us talk few important points about LCIS. Now it is not considered as in situ carcinoma, it is considered as a benign, so it is removed from TNM staging also. Now LCIS meaning lobular carcinoma in situ, right? So lobular, BL is bilateral and multicentric. It has microcalcification which are called as neighborhood calcification. This is an important point from PATH. Neighborhood calcification is seen in. They give you options like LCIS, DCIS, Paget's disease and some other inflammatory carcinoma of breast. So you need to answer LCIS, neighborhood calcification. Most common to present as occult primary carcinoma. In DCIS, it was the most common to be detected in screening mammography, right? Here it is most common to present as occult primary carcinoma because the diagnosis is incidental diagnosis. They don't have any symptoms per se. It is just an incidental diagnosis. So LCIS have the potential to convert into invasive lobular as well as invasive ductal carcinoma. When it gets converted into invasive lobular carcinoma, it gives a pattern of Indian file pattern or single file pattern on histopathological examination because the cells are actually adhered because of E-cadherin protein coded by CDH gene. When the E-cadherin is lost in this invasive lobular carcinoma, cells are separated from each other, so they give us the appearance of Indian file pattern. The same mechanism, E-cadherin mechanism, is seen in gastric carcinoma also. That is in Linitis plastica. Same cadherin mechanism is seen. Remember that point. Both places you get CDH. When we talk about LCIS management, if the margin is positive, there is no active management for that. If LCIS turns out to be pleomorphic LCIS, then the treatment is same like DCIS. That is, you again do that Van Nuys grading and you take the scores and you manage further accordingly. So this is about LCIS. Now when we talk about the TNM staging of the breast carcinoma, in the TNM staging, we include DCIS and Paget's, but LCIS is not included because it is considered as benign. For the diagnosis, the investigation of choice is true cut biopsy, whereas for staging, it is PET-CT scan or CECT thorax abdomen plus bone scan. Because the metastasis is most common to bone, we need to do bone scan if we apply CECT, or directly you can do PT-CT scan. And this TNM is applicable for DCIS and Paget's as already discussed. So there are 4 stagings, right? T1, T2, T3 and T4. So T is for tumor. When T2 is for 2 to 5 centimeters, so T1 is less than 2 centimeters and T3 is greater than 5 centimeters. When we talk about T4, T4 involves the anatomical structures. So A, B, C and D are there. A is for chest wall like ribs, serratus anterior muscle and intercostal muscle. Whereas B is for skin. C is for combined like chest wall and skin. And 4 is inflammatory breast carcinoma. The thing that you need to remember here is which are not considered under the classification of TNM staging. Like if pectoralis major and minor is involved, there is nothing to do with chest wall. Okay, in the chest wall here, we only categorize ribs, serratus anterior and intercostal muscles. There is no pectoralis major and minor in TNM staging. In the same way, dimpling and retraction are also not considered in TNM staging. And there is one more question here. They usually ask, dimpling is because of. Dimpling is due to involvement of ligaments of Cooper. So remember it as dimpling has ligament in it. whereas retraction is due to lactiferous duct involvement. So these are the two important questions that they always ask you, and they give you in the question that pectoralis major or minor is involved. So we tend to confuse that it is chest wall involvement and we put it under T4, but that is not actually right. Pectoralis major and minor are not included in the TNM staging of breast cancer. So now T stage is done. Let us go to N stage. So N0 is for NO, no lymph nodes. N1 is axillary lymph nodes which are mobile. Whereas N2 is having A and B. N3 has again 3. 2 has 2 divisions, A and B. 3 has 3 divisions, A, B, C. So when we talk about N2A, this mobile lymph nodes now get fixed. Same axillary lymph nodes. Whereas B is internal mammary lymph nodes. So A is fixed axillary and B is internal mammary lymph nodes. Coming to N3, so first is infraclavicular and C is supraclavicular. So remember it as SA for SA. C is supraclavicular, A is infraclavicular, and B is exactly equals to N2, whole N2, that is A plus B, which is axillary plus internal mammary lymph node involvement. If contralateral lymph node involvement is given, that is the lesion or the breast carcinoma is detected on right side and you see lymph node involvement on the left side, then you take it under metastatic, that is it goes under M staging. It is no more an N staging. So N staging is done and T1, T2, T3, T4 is done. So now we are left with M staging. So M0 is no metastasis and M1 is distant metastasis. That is also most commonly to the bones. And the question that you get here is, the bone metastasis in breast carcinoma is mostly of osteolytic type greater than osteoblastic type. Osteolytic greater than osteoblastic. Remember here itself that in prostate carcinoma, it is osteoblastic more common than osteolytic. For breast, it is osteolytic more than blastic. For prostate carcinoma, it is osteoblastic more than osteolytic. Remember this point here itself. Now coming to the most important prognostic factors. If the metastasis is present, then look for ER-PR status. If the metastasis is absent, then look for axillary lymph node status. Coming to the treatment of breast carcinoma, everything is mentioned in your notes actually, but they usually ask you about large operable type of breast cancer and locally advanced breast cancer. So this is what I got to know by solving the questions and all. So mostly they concentrate on these two types. So I have made a mnemonic for that during my preparation. So I want to tell you that one now. So remember it as 300 and 310. Okay. Large operable is 300. It is having 0 O in it. So zeros. Is locally advanced is 310. So what is this 300 and 310? 300 is T3, N0 and M0. Whereas 310 is T3, N1 and M0. So divided between T, N and M. So when the staging of the cancer is T3, N0, M0. So shall we revise it here? N0 meaning no lymph nodes, that is okay. M0 meaning no metastasis. What is T3? T3 is greater than 5 centimeters, right? So when in the question it is given that the lump size is greater than 5 centimeters and there is no lymph nodes involvement and there is no metastasis detected on PET scan or something like that. So then it is 300, that is T3, N0, M0. So the diagnosis is large operable breast cancer. For that, treatment is, since the breast cancer is large, we give neoadjuvant chemotherapy so that the tumor shrinks. Then you can do breast conservative surgery. Okay, that is the treatment. When we talk about locally advanced breast cancer, so it is advanced, right? So increase by 10 number, 300 to 310. So 310, T3, N1, M0. M0 should be constant. Metastasis should not be there for the treatment. Okay. So M0 is constant, but T3 and N1 can change to higher numbers like above T4 and N1 to N2. So overall T3, N1, M0 or T4, N1, M0 or T3, N2, M0. Anything like that. Like T3, N1, M0 is the baseline and above that anything comes under locally advanced breast cancer. So the treatment that you give for this is same neoadjuvant chemotherapy and here you do modified radical mastectomy and then you give radiotherapy. If the tumor is ER-PR positive, you give hormonal therapy like tamoxifen. If the tumor is HER2 positive, you give trastuzumab. So this is the treatment they usually concentrate on, but you need to read everything from breast cancer. All that I have included in this video is what I felt most important. So since we talked about MRM here, that is modified radical mastectomy, let us discuss in detail what is modified radical mastectomy. So there are mastectomy types that you need to remember: simple, modified radical, and radical. Remember in the same order, because as you go towards this end, radical end, more organs you remove, like more structures you remove. In simple, you only remove breast, nipple areolar complex and pectoralis fascia. Whereas in modified radical, you remove all these three plus levels of lymph nodes like 1, 2 and 3, and pectoralis minor may or may not be removed. Whereas in the radical, you go like extensively. You remove pectoralis major and minor also, along with all these three like breast, NAC, pectoralis fascia, levels, and these two, pectoralis major and minor. When you talk about pectoralis minor incisions, so there are three types: auchincloz, scanlon and pate. In auchincloz, you just retract the muscle fibers. In scanlon and pate, you cut the muscle fibers. So this is an important question again. In scanlon and pate, you cut, whereas in auchincloz, you just retract the muscle fibers. And here I have written the examples like the diseases in which simple mastectomy is performed. It is Phyllodes, Dcis and toilet mastectomy. So this is about the mastectomy types. Now that we have talked about the levels of lymph nodes, let us understand what are the levels of lymph nodes actually. So axillary lymph nodes, there are three levels: level 1, 2 and 3. So level 1 is from 1, I can write lateral, right? So 1 is lateral to pectoralis minor muscle, 2 is behind the pectoralis minor, and 3 we can make an M from 3, so it is medial to pectoralis minor. I have attached an image also, I'll show that next. So level 1 is lateral, level 2 is behind the pectoralis minor, and level 3 is medial to the pectoralis minor. This is surgical classification. Coming to the clinical classification, LAP, that is lateral, anterior and posterior group, comes under level 1. Central and rotors, other name is interpectoral, that is between the pectoralis minor and major, comes under 2. Whereas apical one comes under level 3. So these are two different classifications of levels of axillary lymph nodes. Here are the images. So green one is level 1, lateral to the pectoralis minor, blue is level 2 and red is level 3, that is medial. Coming to the clinical classification, LAP, that is lateral, anterior and posterior, are towards the first. Whereas apical is below the clavicle there, that comes under level 3, that is subclavian or apical. And level 2 is behind the pectoralis minor muscle. Here is another image from my notes. So this image shows you the terminal duct lobular unit, which is in green color, and large ducts and interlobular stroma. So interlobular stroma is all about fat tissue. So you have fat necrosis and lipoma there. So fat necrosis, important point is it mimics breast carcinoma both clinically and mammographically. And the other thing that you need to remember in this diagram is intralobular stroma. So interlobular stroma is done. Intralobular stroma, the two important diseases that occur in intralobular stroma are two Fs. One is fibroadenoma, one is phyllodes. So both are pronounced as F, right? Fibroadenoma and phyllodes, both are intralobular. Coming to the large ducts, the name itself tells duct is ductectasia, duct papilloma and squamous metaplasia of the duct. The only thing that you need to remember here is Paget's disease that come under large ducts category. Coming to the TDLU, that is terminal duct lobular unit, here LCIS comes. Lobular carcinoma in situ comes in this terminal duct lobular unit. And the other thing that you need to remember is sclerosing adenosis. Lastly, coming to the genes in breast carcinoma, the important ones that you need to remember are most common gene mutation seen in breast carcinoma. If they ask overall, then you have to answer it as P53, that is Li-Fraumeni syndrome. When they ask you about familial breast carcinoma, then you have to answer about BRCA. So BRCA also has BRCA 1 and 2, right? So 1 is chromosome 17q and 2 is chromosome 13. So 3 minus 1 is 2. Remember like that, 13q is BRCA 2, whereas 17q is BRCA 1. Check 2 mutation is also seen. Double it, like check chromosome 22. Check 2 is chromosome 22. BRCA 2 is 3 minus 1, 2 and BRCA 1 is 17q. So I have made a mnemonic here because they usually ask the chromosome numbers for BRCA 2 and BRCA 1. Okay, so 2 is derived from 3 minus 1. So these are the genes that you need to know in the breast cancer. So guys, I have only involved the points that we usually tend to forget and that are usually tested in breast cancer. So there is a lot to read in breast cancer. Don't skip the topic just by watching this video. We have to go through the notes also. If you like this kind of content, please do support by liking, sharing and subscribing to the channel. I'll come with more such videos. We also have a Telegram channel. The links to which are provided in the description below. Thank you.